about current and future use of integrase inhibitors. Well, let's have a look. I'm going to go through some of these things relatively quickly because most of you know them, but I think it just gives you the basis for some of the reasons integrases are where they are today, at least in my part of the world, and it looks that they might be coming to your part of the world in a bigger way sometime soon. Okay, starting treatment. First of all, I put this up because everybody's starting at every CD4 count, and lots of countries are now moving towards this. And I heard that one of the countries I'm doing a project in, Tanzania, are going to move towards this soon. And the reason for saying it is that we are going to be treating all these patients, and we need to get used to the fact that integrases may be coming for many of them. So we need to know the data. So the real problem is, for most of us, is when we make this decision about what therapy to start with, and we have all these guidelines, and what happens is that if I said to you, please come on my guidelines committee for, say, British HIV or for EACTS, come and sit down, look at all the data, and at the end of the data, please give me a list of what you're going to do in terms of first-line therapy. Well, this is what you get. You get a mess in a way, because if you, I'll just make sure that, that's that, is it? I'm pressing the wrong button now. I want the light.
There should be.
Someone's stolen it. Okay, well, I'll point with my finger. So, if you look down the columns, so EACTS and DHSS here, right, they have, basically, they've still got darunavir. Oh, great. They've still got darunavir. Okay? But when you come to Spain, they've only got raltegravir and dolutegravir. They haven't even got elvitegravir. When you come to BEVA, we've kept both atazanavir and darunavir. And then when you come to the IES USA, they have actually moved towards everything very similar, actually, to Spain, but they've included elvitegravir. But actually, they say no TDF, use TAF. So they are very different. And if, as you know, WHO says efavirenz, and all these others say no efavirenz. So what's happened? How do you interpret all of this? It's quite interesting if you had a meta-analysis of the guidelines where you might end up. So we have to agree to disagree. That's all we have to do at the moment, and we need more studies to find out what's going on. Okay, so the first thing is, let's look at some other data. Well, Andrew Carr's group looked at the efficacy of third drug classes, and they compared here as a reference a non-nuke versus integrases and boosted PIs. They got all the data out. And actually, integrases were basically better efficacy compared with non-nukes and boosted PIs, and about 12% better overall in all the studies. But the studies went back a long time when some patients were taking lots of drugs, so there were some criticisms. But it was a hint that integrases were performing better than our other drugs. And then we started to see what is a sort of a campaign against efavirenz, right, and against PIs. And this came about by many things. First of all, the integrases started to be used in clinical trials against efavirenz. We used to have nalfinavir as gold standard, then lopinavir as gold standard. Now we have efavirenz as gold standard. That should go. We should put all new trials up against integrases. And there were worries about toxicity and about this thing called suicidality. So first of all, this clinical trial showed that even out at 96 weeks, about 4% of people on efavirenz still have problems with dizziness, compared with almost nothing if you look at an integrase stribald here or a boosted PI. And people started to think about, well, yeah, I have got a bit of dizziness. I don't sleep so well. I want to switch off. So efavirenz started to get this reputation of having, and you can see from the data it's true, more long-lasting side effects than other drugs. And then the ACTG did analysis and found that actually, if you were on efavirenz, you had more chance of either killing yourself or attempting to kill yourself than if you weren't on efavirenz. So this really set, as we say, the cat amongst the pigeons, and people started to say anyone with any mental health issue shouldn't be on efavirenz or should switch off. So people started to do it. And then the insurance companies who have big databases in the US looked at their suicidality, and there's the line of unity. Here it is, two big studies. They didn't find any risk with suicidality. But you say, this is a cohort. The other was clinical trial. We've got to believe in the clinical trial data. But then I say to you, what about the abacavir story? People start to believe the cohort data, and they don't believe the clinical trial data. So we're very fickle in what we want to believe and how we take things forward. And then lots of studies were done looking at all the different responses of ephedrins versus other drugs, and basically almost everything was beating ephedrins. And the nail in the coffin for ephedrins in terms of clinical trials started with raltegravir, when they did another analysis out here at 96 weeks and found that raltegravir, which was taken twice a day, was beating ephedrins. I think I've got these the wrong way around, but never mind. So then people were interested in the next clinical trial, actually head-to-head, which was the single trial, where dolutegravir was put up against ephedrins. And if you look here, 88 versus 81%. And in fact, dolutegravir was superior. And it was all driven, almost all driven by, look, adverse events in the ephedrins arm. Remember, this is double-blind placebo-controlled, even though I don't know if you can really double-blind ephedrins in any clinical study for people who take a pill. And basically, as you can see, it was mainly adverse events, 5 versus 1, 4 versus 1, etc. So ephedrins started to lose its grip as the drug of preference. Stribald was put up against ephedrins, and it was non-inferior, so you could use Stribald. And remember, the issue with Stribald is it's got a booster in, so there might be more tolerability issues there with Stribald. And then there were studies in women with integrase inhibitors. And this time, they thought, well, what about a PI? Because women were given PI for very many reasons, and the worries about pregnancy and ephedrins, which of course have gone away, and all sorts of issues. So we saw ephedrins disappearing, but what about PIs? And you can see that the number of women in trial is woefully low, and we need to get more. I mean, trials done here in Africa is much better, but trials elsewhere to license a drug are woefully low. So there was this WAVE study. So they said, was Stribald, which has got elvategravir in, would it be non-inferior to atazanavir, ritonavir? And everyone thought it would. And this is wonderful because it's all women trial. No men allowed in this trial, right? So all women trial. And basically, you can see that overall, in all of these, and especially in greater than 100,000 copies, it seemed to be outperforming it. And most of it actually were related to discontinuations with the atazanavir. 2.4 only in the Stribald versus 7%. And again, it was a sort of superiority in terms of the integrase. So here's the data, and I've said the PIs are in here. Darunavir is still in here for EACS and BEVA. So atazanavir seems to have gone, although BEVA like it. But why Darunavir is still there? And why there's no PIs in the Spanish and the IAS guidance. Darunavir is in EACS and DHSS, and it's only the way you interpret the data. So I've shown you some data why PIs disappeared first line, but this study really was the big study from these states. And you need to know about this study, because this study asked, if you can't use ephedrins first line, and you can only use an integrase or a PI, what would the result be? It's a huge study. You can see 1,800 patients in this study. Now, it's open label, and the problem is you were allowed to switch. And in fact, if you were on the ritonavir arm, you had to buy the ritonavir. So there was some difficulties. So switching away from anything with ritonavir might save you money. And if you switched, you could stay in the study. So you weren't out. So imagine you're poor. You can see some of the things that could affect this study. So what happened was that if you looked at the data of atazanavir versus raltegravir versus darunavir, and you look out to 96 weeks, and you say, if you had to change, it didn't matter. Let's just do an intent to treat. They're all the same. But if you said that anybody who switched was a failure, you then see that BD raltegravir beat darunavir, which beat atazanavir. And atazanavir performed rather poorly. You can see the data at the bottom here. And why was this? Well, for atazanavir, most of it was around GI toxicity and jaundice. And a lot of the GI toxicity was jaundice, because when you went down the list, some people didn't read down to the jaundice bit, and they just say, oh, it's GI, we'll just tick that. Jaundice is something to do with the gastrointestinal system. Well, last time I did GI medicine it was. And so they put that in. And interestingly, there were some people with only biochemical jaundice who had no problems with the atazanavir who were still switched by the docs. Now, that may be related to the fact that the doctor thought they looked jaundiced, but it didn't worry the patient, or that they were on ritonavir and couldn't afford it. I don't know. So, and then another study came around, again saying PI shouldn't be used up front, and it was the Flamingo Study. Dolutegravir versus darunavir ritonavir, and again, superiority. This again was open label, and you really have to be a bit concerned about interpreting open label studies. Because imagine I get randomized and I get put on the darunavir, and I go, actually I wanted the other drug. What can happen is in the first few weeks you come out of the study. You say, I'm not feeling well, or I can't cope with this, or I'm not coming back to the clinic. It can affect the results. So you just have to be a little bit careful about that. The other thing is, though, what can affect the other side, dolutegravir arm, is it's a new drug. So if there's a new side effect occurs that you'd know about if it happened with a PI, but you hadn't seen it before with an integrase, you may stop the integrase. So there are pluses and minuses to be in either arm of this study. But it was superior. So suddenly, efavirenz has become down the list, and boosted PIs have come down the list for first line. So the next thing to say is, could we use 2 drugs rather than 3? And this is this has been going on for years and years, and we may eventually come to some dual therapy that is really useful, and I'm very cognizant that the guy that's been pushing this forward and got great results is one of our chairmen here, Pedro. So there have been 7 randomized trials of a PI and raltegravir, and actually they've not performed as well as a 3-drug regimen. Right? Some are switches, some are naives. And it's really interesting that if you look at the NEAT study, which I was very much involved with, we thought that by giving a boosted PI plus an integrase has got to be fantastic. It's going to get the viral load down, it's going to work really well against a triple arm with all the toxicities of tenofovir in there. Okay, we thought it would work, but actually it didn't. Actually, what happened was it only worked in those people that had, I'll go to the next one, in those people who had CD4s greater than 200 and in people who had basically a low viral load. And we still are unsure as to the reality of why that happened. And there have been other studies where they've been put together and not so great results have come about. And so be very careful in first, these are naive patients, of giving a boosted PI plus an integrase together until we've got more clinical data. Dolutegravir wasn't used here. We haven't used elvitegravir here, so we don't know what would happen with them. Maybe it's something to do with raltegravir and darunavir. When we move on to second line, well, this was the great hope that people, say, in the WHO regions, if they failed therapy, they go from pill A, 1 pill, A tripler, to a second pill with darunavir, dolutegravir. So this would cost $100, that would only be $250, and we use a lower dose darunavir. Nobody was interested. Well, we were, but no pharma company were interested. And now they're going to make an 800 milligram with dolutegravir with Gates involved, and I think the pill's going to be sort of a bit like this to try and take. But we'll see. They might have to make 2 pills. So one of the studies in second line actually was Earnest. And of course, these people here needed second line therapy, and lopinavir, ritonavir with raltegravir, okay, versus standard treatment. They did do this, giving an integrase plus a boosted PI, and then after a while gave monotherapy. But this arm, let me just say, it looks a disaster on paper after the NEAT study, and it was a disaster in reality. But actually, the other 2, whether you gave a PI and raltegravir or recycled your nucleosides, was all fine. So you might ask yourself that actually, maybe this sort of strategy of, in second line, of giving an integrase isn't a great one, and you should use, as Mark said earlier in a comment, think about integrase first line all the time. You've seen this, I know, these, again, second line lepivirine and lopinavir plus raltegravir versus the best available, and it basically came out the same way, so as the Earnest trial. And the thing is now, is we have to try and get our heads around the fact that maybe an integrase plus a boosted PI will have its use, but probably not in second line, and keep the integrase up front. There are people who are virologically suppressed who we can switch. So those other guys were all second line failures. Now, switching treatment is a real fashion. Everyone loves to do it. A new drug comes along, and then the doctors love to switch it. And sometimes we're told to switch because the guys with the money tell us to switch to cheaper drugs. So switching happens. But we wrote this a while back with Jenny Hoy and Andrew Carr to basically say that a switch trial is only ethical if you can meaningfully benefit from the treatment change. You've got to have an advantage from switching. So sometimes it may be related to the fact about future possible toxicity, like come off the AZT, you might get lipodystrophy, or others is that people have got side effects, which are unacceptable. But not just to switch without any reason because, we got a trial and let's just try this drug out. So, the guidelines aren't great about switching. They have all sorts of lovely language, but if you're looking for a cookbook of switching, you're not going to find it much in the guidelines, except for some principles. Be very careful how you switch. This was Switchmark, which is switching to raltegravir from people who are on a boosted PI who are undetectable. And you can see that actually switching to the Integrase was worse. Now, these people were undetectable, but as Pedro said earlier, their history of a lot of these people were a failure. They'd gone on the boosted PI, become undetectable, then for some crazy reason, someone decided to put them in a trial where they'd be given an Integrase plus nukes, probably thinking that you won't, Integrase will protect you against resistance. We have to be aware, well, raltegravir didn't do that. Okay, so be very wary about giving raltegravir and nukes to somebody who's got a history of failure on nucleosides in the past. You can see here. It performed pretty well, but it didn't perform greatly. Interestingly, these guys did the same in Spain and didn't find a difference. And it may be that most of those people had been 6 or 7 or 8 years undetectable before they switched, and their reservoir was so low that actually the raltegravir held it all together, okay? And so that's probably why this worked. But we need to, in science, do more trials to find out if we have people with background resistance or history of resistance, if they've been 20 years, 15 years undetectable, can we switch them to something different that might, be better for them because they've got problems on what they're on at the time? Okay, there have been lots of other switch strategies. So this is all to now alvitegravir. Switch strategy from a boosted PI to alvitegravir worked pretty well. Switch strategy from an NNRTI to alvitegravir worked pretty well. So you can see here that actually going from an NNRTI to alvitegravir or from a PI to alvitegravir, you got very good results. So if there's a reason to switch, and a lot of these people did, hopefully all of them in the trial had some reason, then you can switch to Stribald. Striving was one of the trials I want to just highlight. Here, patients switched to dolutegravir as Triamec with the 3 drugs in here. Okay, so they had to have less than 100 copies, no cases of virological failure in the past, and they just switched. And they switched from their baseline art to this. Now, the problem is there was no reason, apart from going to this single pill, for them to switch. It was just asked, do you want to go on to Triamec? And they said yes. And this is the problem when you do these studies. You suddenly find that 10 people discontinued in the dolutegravir arm and none in the other arm. And this is a case of an open trial where, because people went on the new drug for no great reason, they started to, the doctors and the patients, when they had a complaint, they thought maybe it's due to the new drug. And then, if you look at this, probably none of this, or almost none, was due to dolutegravir, but the nature of it, because people didn't say, I really want to switch and I really want to stay on because my other side effects have disappeared, I can put up with a bit of itching for a couple of days, right? Made the difference. So be careful about designing switch trials. Another switch trial which basically didn't work. Here again, we've got raltegravir plus a boosted PI, and this is called Harness. And basically, look at this. These are people who stayed on their triple therapy. These are people who switched to atazanavir raltegravir. Again, for some reason, raltegravir and a boosted PI alone doesn't seem to hold the virus very well. And the only time we've seen it is in the spiral study where people were years undetectable. So there's something odd going on. And I don't know if it's the raltegravir itself, with its interaction with a boosted PI, or some other reason, virological reason. So, yeah, okay, a few more people had toxicity, renal toxicity here, and a few more people had more hyperbilirubinemia with raltegravir. So let's treat an integrase like a boosted PI, right? So let's just give dual therapy. So a lot of patients are giving PIs plus a single drug, and Pedro did a study of lopinavir plus 3TC and had great results, and now he did this study of dolutegravir, but he's been very careful, and this is the study. It's really, and we're going to get an update of this on Friday, 20 patients, right? They were screened for viral loads less than 100,000. They were, although when they came in, a few of them, it went up, that's fair enough, and then they were given, right? They were given dolutegravir 3TC, and he checked the viral load almost daily. It was fantastically well run. In case anything happened, you could abandon it. And you can see in the yellow here that how quickly everybody went undetectable. The guys with the higher viral load took a bit longer. That's what you might expect. And we had the week 24 data, and they're all doing well. So, but let me say, don't do it at home. Do it in a clinical trial. And what's happened now is I had a referral the other day. Could we give this patient dolutegravir 3TC, please, in our virtual clinic? I said, look, only if they're allergic to everything, resistant to everything else, and there's no other way out for this patient. But, and I'm sure people would agree with me who are doing this science, we need the trial data before you start. Look, we can give this patient a triplet, right? And they'll become undetectable, and you know what's going to happen to them. Please, please, please don't experiment with naive patients. It really could cause a lot of problems. When we have the data, we can all wait a couple of years. When we got all the full data, we can say that was a great strategy and we should have done it. Right, this is one you should definitely not do at home, and people are doing it all the time. Now, there may be a scientific basis for it, and Mark Weinberg has spoken about the developing mutation, but not switching to monotherapy. Yeah. No. And these people just switch people because they had reasons, and okay, so that was okay. They had a reason to switch to a monotherapy with dolutegravir. But what happened was, in another study here, in this study, you got a lot of people with resistance all occurring. Right? Switching people is not a great idea, and you got virological failures. And Christine Katlama and the Barcelona people presented this data as if it was fantastic, but actually most of us physicians were worried about how the studies were conducted and what the results were and what the implications are for patients doing this sort of thing. So please don't switch. Don't start people on dolutegravir 3TC, and don't switch people to monotherapy with dolutegravir. Put them in a clinical trial. Put them in a clinical trial. So I think I'm going to just do this last novel approach of long-acting injectables. And basically, this is really interesting because I've said a lot of bad things, really, about PIs plus integrases. And PIs have got great barrier to resistance. And look at this now. I'm now going to talk about a study that's done really well, looking at rilpivirine, which has got a really low barrier to resistance, right, plus this drug here, carbotegravir. And basically, they want to know, because both of these drugs, you can make into a long-acting injectable. So, and what you want to really know is if you put the two together, okay, will you be able to maintain virological control? So the first thing you do is have to give them orally, because if they don't work orally, they probably won't work by injection. So this study what they did was give carbotegravir with 2 nukes to get people basically undetectable. They compared it all to ephedrins and 2 nukes, and then they switched them over as a maintenance phase with the carbotegravir plus the rilpivirine. So this is really interesting. It's like switching to an NNRTI plus an integrase. And they found great results all the way out to 96 weeks, right? Very comparable to the ephedrins arm. Looks like it's slightly underperforming, but you can see it worked really well. And they used different doses of carbotegravir. So now you can think to yourself, well, we can use these as an injectables now, as long-acting injectables. So there's just a bit of resistance data, which you probably saw earlier on today, which was very encouraging. And the adverse events with this were very low. So all of that data suggests low rates of resistance and failure, low rates of adverse events, that you can actually start to give injectables. So here's LATE 2, where you gave carbotegravir with bacavir 3TC, and then at 16 weeks you add the rilpivirine. And why is that? Well, you want to get people undetectable, and then the other thing is you don't want any, if you took rilpivirine and got a side effect to it, like a bad rash, and you'd injected it long-acting, that could be pretty serious. So you want to take it orally for a while. And then they went to these doses of carbotegravir plus rilpivirine, all IM, long-acting, versus this oral continuation phase, okay? So it's the standard oral versus two different doses of injectables, and they all did pretty well. They all did pretty well. And you can see they used 4-week and 8-week IM regimens, similar to the oral regimen, and it looks like we might move towards this now, being given in an even bigger trial, giving long-acting injectables for HIV disease, which is quite incredible. The only problem, of course, just to say something, is that some patients will love this, only coming in every couple of months to have that. And people who are really badly adherent, maybe we could give it as long as they turn up for the next appointment. Badly adherent people don't tend to do that. That's the problem. But there are others who don't want injections. The injections are quite large volume. And I think that what this does, it sets the path for more drug development and looking at perhaps in the future having drugs that you could give at much more longer intervals, maybe 4-6 months. Okay, and the safety you can see here was very good. Serious adverse events were small. Adverse leading to withdrawal, if you look, 3 out of 230. It's very low. So it's just over 1% who came off it because of that. Okay, and the satisfaction with the maintenance therapy versus the oral induction, most people were more satisfied, with the injection than they were with the oral. But you just have to look at this data and think, hang on a minute, who volunteered to go in this study? Maybe people who wanted injections, so what they're going to say. Okay, so I have to be a little cautious. All I would say about this is people were satisfied with it. Okay, so if I want an injection, I have the injection, I'm satisfied with the injection. Well, anyone who owns a shop knows if the customer wants something, you sell it to them and they're happy with it, that's great. Okay, so there is a future, I think a very good future for this sort of development to go on. And finally, other challenges for integrases, which I haven't really put. Pregnancy, few data. We have data on raltegravir, but we've still got few data. And the great thing about integrases in pregnancy is people are using them when people are coming late in pregnancy after 20 weeks. You want to get the viral load down. They've got a high viral load. You want to try and stop mother-to-child transmission, add an integrase to what they're on, or give an integrase regimen. The role in TB, well, we got data on raltegravir from a trial. We got PK with dolutegravir and this trial ongoing. But we really need, if you're going to use this in WHO areas as first-line therapy, it's got to be watertight for tuberculosis, and dolutegravir has got to be watertight in pregnancy. The role in acute HIV infection, again, decreasing the reservoir or even stopping people having symptoms of fevers and sweats, and etc. And, of course, the role in PrEP. But that's another talk. With that, thank you very much indeed.